I welcome you, Sadi Madam, as a chairperson. And as a second chairperson, we have Dr. Kavita Ellis, who is again an upcoming senior consultant in obstetrics gynecology. She's a fertility specialist as well as a laparoscopic surgeon. She has got a hospital in Kattanam, Kayankulam, as well as in Trivandrum, Tirumala. She's director of Sri Krishna Center for Fertility, and she's a managing partner for pharmaceutical distributors. And I welcome you, Dr. Kavita Ellis, for chairing this session. I invite now Sadi Madam to introduce the speaker of the day, that is Dr. Sunil K. Jindal, sir.
Thank you, Reggie. Let me introduce Dr. Sunil Jain, who is having an IVF center at Meerut, and he's a very well-known infertility specialist and laparoscopic surgeon. He's also the vice chairperson of the Delhi ISA and chairperson of the Indian Association of Gynecological Endoscopists. And he has a vast experience of over 5,000 cases of laparoscopy and hysteroscopic surgeries. He is also known for his national and international publications. And I appreciate him for the JINDAL newsletter, which he used to send in 2019. He stopped it after the COVID, but it was a very informative paper and I used to look forward to reading it each time. And over to you, Dr. Jindal.
Yeah, thank you. Thank you very much, ma'am. Thank you very much, ma'am, for the kind introduction. And very importantly, also for the fact that you appreciated my newsletter. COVID stopped it. I'm going to start it from this month itself. And I'm going to write that Madam had inspired me to start it all over again. This is something I'm going to do. But it's Dr. Kunja Moideen, thank you very much for inviting me here to speak about male fertility. And it's been a long time since when I have been practicing. And I'd like to share with you a small story which happened in my life, because of which it became so pertinent to me. I still remember this was the warm summer of 1992. And I was a postgraduate in Maulana Azad Medical College and a surgical postgraduate. At that time, we had a professor known as Dr. Ramchandra Murthy Kaza, who used to specialize in urology and andrology. And the unit was a unit which has urology, andrology with surgery. So this andrology theater used to always get time after 2 o'clock. And there was one patient of Azoospermia. I was assisting Dr. Kaza. And this patient was of non-obstructive Azoospermia, and they were planning at that time, we were planning to make a pouch to get sperms in. So after about 3 hours of work, it was very warm, we were sweating. Finally, Dr. Kaza and we together found one sperm in the microscope. So he screamed with delight and said, "Wow, I have found a sperm." But the next thing which came out of my lips was, "But sir, what are we going to do with this sperm?" Because the truth remained that there was no ICSI, and there was nothing which you could do with those sperms. So after that, when in 2002 we started ICSI, the dots joined and realized that this sperm, which we had nothing to do, and we couldn't even freeze it at that time because we did not know freezing in that college, this sperm can be used to do ICSI. And this is the magic. And this magic brought us further into a situation where today 70% of azoospermics can have their own sperms. So I've been given half an hour. I'll briefly like to take you through a small journey of how exactly and how beautiful these sperms are, and how these sperms could give fatherhood and the actual fatherhood to men who are azoospermic. I'd like to just start sharing my screen. And of course, at the outset, I'll thank the organizers for inviting me and giving me the opportunity to share a part of my life with you. So the key concepts about which I would probably speak over here is that the sperm count is going down over the century. And we know that the sperm count has become 50% of what it used to be a century back. Now, semen analysis is the initiation of the investigation. A lot of new diagnostic tests are there which have come up. We also know that antioxidant supplementation is a hot issue today, and DNA fragmentation of the sperm is another topic altogether. And there's so much available today on which we're going to speak today on Azoospermia, and biological fatherhood is possible even in the worst case scenario. And spermatogonial stem cells represent a novel and beautiful reproductive regenerative medicine. So let's go on to Azoospermia. Something for us to understand very simply is you have a pretesticular, you have a testicular, and you have a post-testicular Azoospermia. So a pretesticular would be wherever the hypothalamic pituitary axis has less of FSH and LH, which is hypogonotropic hypogonadism. Post-testicular would be obstructive Azoospermia. There has been a vasectomy, epididymal problems are there. There is problem with the ejaculatory duct. There is problem with the retetestes. And primary testicular failure is where the testes per se is not functioning properly as post-cancer survivors. You could have patients like Klinefelter syndromes, Sertoli-only maturation arrest. So now let's just look at the way Azoospermia would be classified, because the treatment and management will go hand in hand on the way the Azoospermia is. So it could be obstructive, which we have spoken about, where there could be mechanical blockage, vasectomy, post-infectious, congenital. Can I make a request, please? Can everybody mute their mics, please? Yeah. Thank you very much. Thank you. Then you could have non-obstructive Azoospermia, where the sperm production. Can everybody mute their mics, please? Can mics be muted by everybody, please? Yeah, thank you very much. So now this is a beautiful slide which I'd like to show to you, in which there are two types of, I would say, Azoospermia, obstructive. So what happens in obstructive is that you have a normal size testes, the endocrine profile is normal, and there is a mechanical blockage. So the spermatogenesis is normal. Then you can have two types of non-obstructive. One is a spermatogenic failure, where the FSH, LH are high or normal, where the testosterone is low or normal, and the testes are small or normal. And this is where spermatogenesis is disrupted. Now, the other which you could have is hypo-hypo. So in hypo-hypo, the FSH and LH are low, the testosterone is low, there are small testes, there's poor virilization, and it is disrupted. So this is the way you very simply can divide Azoospermia. And this division of Azoospermia is important because we would like to plan further on depending on the type of Azoospermia. So first of all, let's talk about hypogonotropic hypogonadism. So what happens in hypogonotropic hypogonadism? That a patient comes to you and the patient has poor virilization. You examine the patient, you would find small testicles. You get the FSH, LH, testosterone done. All the three are low. So these are the patients who have excellent results. I'll tell you a beautiful story which happened with me about 12 years back. I had known somebody very closely, a very rich lady whom I had known for ages. She came to my clinic, and after coming to my clinic, she asked me a beautiful question. She said, "From where can I buy the most expensive sperm in the world? So it was a very weird question. So I looked at her and asked her, what's the problem? So she showed me some reports, and her son had been diagnosed hypogonotropic hypogonadism when he was young before marriage, got married, and now there were no sperms, wanted to have children, and was told that, well, you'll have to get a sperm from outside. So she went out to buy the most expensive sperm in the world. So I remember I told her that I do not know about the most expensive, but the most valuable sperm is going to be your son's. There's a difference between expensive and valuable. So she said, okay, but how? So I told her this, and we started him on HMG, SCG. And after about a month or so, when his testosterone became okay, I think it took about 6 weeks, then we put him onto HMG. And after about 4 months, we got sperms. They were low in number. We did ICSI for them. And the first cycle did not get pregnant. Second cycle got pregnant. We transferred 4 thinking that, well, we didn't really know if pregnancy would be there. And there were quadruplets, did a fetal reduction, finally gave birth to 2 beautiful babies. So this was the first case of hypo we had. And after this, we have a series of patients. Let me tell you one thing. Even this gentleman till date could have been on testosterone, but he still takes SCG and HMG because it has changed his life, his sexual life completely. So now let's go on to the different sperm retrieval techniques which we have. So we have different sperm retrieval techniques for obstructive Azospermia and different for non-obstructive Azospermia. So you have PSA, which is percutaneous epididymal sperm aspiration. You have MESA, microsurgical epididymal sperm aspiration. You have TISA, where you actually put in a needle into the testes to aspirate from the testes. You could have TESE, in which you do a biopsy from the testes. And then, of course, Microtesa, which has revolutionized and changed everything, where you open up the testes and under a microscope see all the tubules, and you would then like to take out any of the tubules which are different, take out sperms and use them for ICSI. So these are the different techniques which are available. So I will show you each technique the way it is. So when we do a PISA, I hope you can see the video over here. So when you do a PISA, what you do is you take the most dependent and the most turgid area of the epididymis. You could use a BD syringe which has, you could use a BD syringe, and in this you have a little bit of media. You would like to put it into the epididymis. Now the trick in this is to get the epididymis at the most turgid area, put in the needle, give the correct pressure, and take the aspirate. Now in obstructive Azospermia, if you want a very good harvesting, it is better to go ahead with a MESA, which would be a microscopic. You open it up, under a microscope, open the tubule and take out the material. It is much more gratifying that you can freeze a lot of it, but PISA gives you adequate too. So there is no problem in PISA in obstructive Azospermia. Now this is the way an epididymis appears when it is full and turgid and full of sperms. So in a MESA, what we normally would do is we'll open it up from here, aspirate and take out all the white material. After we have taken out this, we're going to freeze it and close it back. Now, supposing you need to do a testicular extraction. Normally, I do not do a testicular extraction, but I would do it only in a condition where I know it is obstructive Azospermia and PISA has not yielded me sperms. So what I normally would do is I would take a 16 gauge needle, take a 20 ml syringe. The 20 ml syringe is for the pressure which would be given. And once the 20 ml syringe is there, Once the 20 ml syringe is there and pressure is put in, I would like to put in the needle and just pulverize a little bit of the tissue to get as much tissue as possible with sperms. Now, the sperm retrieval success in obstructive azoospermia is very good. Can I please request Galaxy A8 to please off their mic, please? There is somebody whose mic is on. Please mute yourself. Thank you very much. Can I ask you to mute your mic, please? It is Galaxy A8. Please mute your mic. Yeah. So whenever you do a sperm retrieval in patients who have obstructive azoospermia, this is Galaxy A8 bracket 20. Can you please mute them, please? Galaxy A8 plus 20. Dr. Reggie, can you please mute them? Yeah, muted. Yeah. So the success rate in obstructive azoospermia is nearly equivalent to the success rate which you have with a normal sperm, which basically means that you are able to get a fantastic number of sperms. And since in most of these patients, the lady does not have any other problem and she's waiting for embryos, the success rate in obstructive azoospermia is fantastic. If you go on further and you compare the usage of sperms which have been surgically retrieved, and you compare them with the sperms which have been ejaculated, you will see that the fertilization rate, the pregnancy rates, as well as the miscarriages, all are about equal, which means the human sperm which has been retrieved has about the same success rate as an ejaculated sperm. So the ICSI outcomes, of course, of obstructive azoospermia are again in another study comparable to fertile donors. So that way, if you look at it, it is one fantastic procedure which gives excellent results. But then let's look at non-obstructive azoospermia. So non-obstructive azoospermia is like you have apples on a tree. There is a testes. It has very small and few areas where you have apples, which means area of spermatogenesis. And these are the areas which you need to get hold of so as to get sperms. So what do you have over here? So, well, if you want to do a TSA, you could do, and you know that there is hypospermatogenesis or spermatogenesis is present, then all that you need to do is give a small incision in a window, take out the sample, and this is just the kind which way you would give one stitch to the testicle and one single stitch to the scrotal skin. So this is a beautiful procedure where you would like to just take it out from one area because you think there is hypospermatogenesis. But in case there is non-obstructive azoospermia and you do not do Microtesa, so one of the techniques which you can use is to do a testicular sperm extraction and a multiple biopsy sperm extraction. So this is something which normally I do not do. This is a very old video which I had, in which after taking out this testes, this patient had been operated earlier, had come with a diagnosis of maturation arrest. So we decided to open the testes in multiple areas. And after opening in about 8 areas, different areas, and taking out biopsies from these different areas, sperms were looked for in these areas so as to go ahead and do ICSI. So in any case, in a patient with non-obstructive azoospermia, if you are not doing Microtesa, then you could go ahead and do multiple biopsies so that at least one area could be there from you could get sperms. So now the question is, how do you prepare testicular and epididymal spermatozoa? So it's beautiful because God has blessed, God has been so kind that apart from surgical, even the laboratory andrology excites me. So it's given me a chance where I could surgically do the work, I could clinically do the work, and laboratory get a sperm to do ICSI. So the whole spectrum is beautiful. And just after you have stripped the whole seminiferous tubules, and you would like to see if any sperms are present. So this is the kind of, I would say, coagulate which you find, in which you would like to take out the sperms. Now, what I had started doing now is in non-obstructive azoospermia, I started doing a needle mapping of the testes. And in this, what we do is that if you see over here, and if you mark out about 16 areas in the testes, because see, it's just like an apple tree. You have apples at a few places, but there are green leaves at the other places, so you want the apples. So in these patients, you would mark out the areas, put in a needle, do a TISA in these areas, and once a TISA has been done, you have a Petri dish which has 16 drops. So you would put out the aspirate into one of the drops, mark out 16 drops, and then once it goes to the laboratory, you would know which is the area where sperms would be present. This would be needle mapping. But even a, but what happens is at times you don't get too much of tissue in this. And you need to at times go into the testes and operate. Well, that's what we want, to go into the perfect area. But sometimes what we do is you've opened the testes and you would mark 16 areas on the open testes. And once you mark 16 areas on the open testes, just like I had shown you there, so over here you could go ahead, put in the needle similarly, pull out, take the aspirate. And what happens is when you take out the needle under pressure, negative pressure, you take out the tubule, a tubule comes out. So just with a micro forceps, if you hold the tubule and just start pulling it out, you get a reasonable amount of tissue. So you actually would be in a position to get a good amount of tissue from 16 such places, or in fact send them for testing right away and just call it a day with the moment you have found sperms. So this is a beautiful procedure. Believe me, it's such an amazing procedure that you find the area where sperms would be there to open them up. But then, of course, the gold standard is Microtesa. So what we do under Microtesa is we open up the testes, first of all in the first plane, and under microscope, which could be about a 20x magnification, you would go ahead and see the tubules. You can see the tubules which are thicker, bigger, and from these tubules, and these are the tubules which you normally are going to pick up, place them in a dish. And once you have placed in the dish, these are the tubules which will go into the laboratory, stripped to find out sperms. And you'd be able to get babies out of these sperms which have been got out of it. So this is the way you would normally do a microtesa. It's a very safe procedure. When you close the testes, it gets into its normal shape. It is not very traumatic as it appears to be. And this is the way the testes would normally, after splaying, the whole of it appear to be. But when you close it back, this is the way it gets closed completely. And these are the Eppendorf tubes which will have different tissue, which we are going to strip to find out sperms from them. So this is how it appears to be. Like this would be an area where if you see the tubules are a bit thicker in this area. So all that we're doing is just taking out the tubules from this area. And these are the tubules which we're going to place to strip these sperms from this. So this is a PISA sample, and if you see over here in a PISA sample, there are a lot of RBCs, and you would find a few sperms, and these are the sperms which you'd like to pick up and take them for ICSI. Now, the key messages which I would like to place over here is that in obstructive azoospermia, the sperm retrieval and lab processing is simple. Sperms are obtained in nearly all the cases. Chances of retrieval and ICSI outcomes are independent of the obstruction etiology, independent of retrieval techniques, independent of sperm source, and the results are similar or better than ejaculated sperms. But in non-obstructive azoospermia, which is the challenge and the most beautiful area to work in, sperm production is deficient or absent. Overall retrieval rates are about 50%. It's very labor intensive. At times it takes about 3 to 4 hours and the eyes start watering till the time you would say that, well, I'd like to call it a day. But sometimes when you get a sperm after 2 hours of working, you think it was worth working for 2 hours. And the retrieval rates are dependent on the technique. Microtesa yields better sperm retrieval rates, and the predictive factors as testes, histology, and Y chromosome are what need to be done before we actually, I mean, if you have a histology, you would know how the retrieval rates would be, but a karyotyping and a Y chromosome microdeletion needs to be done. And of course, the reproductive potential is lower in ICSI in non-obstructive azoospermia than obstructive azoospermia. So now the future, well, I'd like to talk about it for a minute because this becomes very important. The future is not only bright, very bright. It's very bright. Sperm biomarkers would be used as diagnostics and treatment. Male fertility preservation is going leaps and bounds. Stem cells will be used and are being used as new agents for treatment in male infertility. In non-obstructive azoospermia, I'll just show you a slide over here. See, what has happened in Japan, they have taken out spermatogonial stem cells from mice and cultured them in the laboratory to prepare sperms in the laboratory. These sperms have been micro-inseminated in mice to get mice. So if this was possible in mice, it's also possible in humans. The problem at the moment is that the proper culture media for spermatogonial stem cells has not been made, but it would be made in the future. So all those patients in non-obstructive azoospermia, where we cannot get their sperms, we probably would harvest spermatogonial stem cells, culture them into sperms, and give them their own baby. CRISPR, of course, all of us know that CRISPR-Cas9 is the most amazing technology in the world, where you can replace the DNA code just like the viruses replace in the DNA. And this replacement could lead to embryos free of diabetes, embryos free of thalassemia, but it could also lead in the future, if it goes without any law, designer babies. Somebody wants Sachin Tendulkar as a child. You could have Sachin Tendulkar as the cricket team captain knew with his genetic code. You could have Katrina Kaif. You could have Madhuri Dixit as your child. So, but this probably would not happen because the cricket teams would have all designer babies. The toppers are going to be designer babies. This will not happen. But this is what the future would be for this world, where more than disease prevention, disease treatment, disease prevention is going to be the way it's going to go on further. In fact, let me be honest, this coronavirus has brought us into an area where people have really understood that medicine and biotechnology is far superior to any other technology for the human race. And more importantly, it has been a beautiful time of collaboration where the whole world has collaborated together to create a vaccine in 1 year, which used to take 24 years. So I think we as doctors are blessed to be doctors at an era which would be the future. And because it's going to be the next 2 decades is going to be biotechnology, genetics, and medicine. I'm quite sure that's the way I would think it would be. And looking at it in a different perspective, today a man and a woman are needed for a baby, but 2 men, when they get married, which is legal and of course it can happen, then one of the men could have a pluripotent stem cell made into an oocyte. And so the sperm from one, the oocyte from another, could give the surrogate a baby. But if the 2 women and they want a baby, one could make a sperm, one could make an oocyte, and one of them could say, well, I want to keep the baby, and could be the biological mother using her womb. But the interesting thing is, they would never be able to have a son. So I would end over here, bringing you a glimpse of the future, the way I look at it. And thank you very much. Thank you very much for inviting me here.
Dr. Satyanadam and Dr. Kavita, please unmute and start the discussion. Request you to start the discussion. Few queries in the chat box.
Now, the first question which is there is, in hypo, what is the criteria of changing HCG to HMG? See, let us understand, HCG is similar to LH. So when you give LH or HCG to the man, you would like to give it till the time that testosterone becomes normal, which means the testosterone milieu in the testes needs to be to a normal level. So you will either judge it by a testosterone assay, or you would judge it by the size of the testes. If the size of the testes has become close to normal, or the testosterone has become normal, that is the time when you would add HMG. So that's the way you could go ahead and do it. So normally it takes about 1.5 to 2 months of HCG for the testosterone to come to normal, when HMG would be added, and when a further about 2 to 3 months after that, you would find sperms. Now the next question is,
Thank you, sir.
Yeah, next question, what is the option in Cryptozoospermia? No, just a minute. What should be the next step after Sertoli cell only has been reported on testicular biopsy? If you have Sertoli cell only, the chances of finding a sperm on Microtesa, I would not say is 0%. You would do a hormonal assay of this patient, see if the testosterone of this gentleman is normal or not. If it is low, or if it is low normal, you would like to give this patient HCG. And so once you have given this patient HCG and the testosterone comes as normal, that is the time that you would plan to go ahead, do a Microtesa, explaining to him that the chances of getting sperm in a Sertoli only would be below 10%. And if it is acceptable to him, go ahead and do a Microtesa. If it is not acceptable to him, give the other options which would be there. Next is, what is the option in Cryptozoospermia and what is the option in Necrozoospermia? It's very simple. If you find a sperm which is normal in Cryptozoospermia, go ahead and do an ICSI. If you find Necrospermia, do a viability test, do along with that a horse test, do a sperm flexibility test. If any of these sperms are live, you could go ahead and do an ICSI. If there is Necrospermia, Necrozoospermia, I've had this patient. I'll just share with you this patient. So this patient came to me with Necrozoospermia. None of these sperms were viable. Not even one sperm was viable. We did a horse test. Nothing was viable. When something like this happened, the only option which we had was, and he said, I want my own baby. I said, okay, fine. So this was a patient whom I remember after correcting the testosterone, which was not much deranged, went ahead and gave him antioxidants for about 4 months. And after 4 months, when we saw the semen sample, we found 4 sperms which were viable. And these 4 viable sperms we used for ICSI to make 2 embryos. So the beauty about this story is you need to just go on and work on these patients, which is phenomenal. Any pre-treatment is required before PSA and obstructive azoospermia. Obstructive azoospermia, if the testosterone is fine, there is no point of giving any pre-treatment. You could go ahead and do a PSA. How to prepare the patient for Microtesa? Well, you've got to shave and prepare the part. Check if the testosterone is normal. If the testosterone is normal, please go ahead and do a Microtesa. Your microscope should be fine. You should set the microscope. Before you're going ahead and doing the surgery, your instrument should be working fine. Your embryologist should be ready. And most important, you need to counsel the patient and tell them the true result of what you expect. Don't overpromise. Next is, what is the highest level of FSH where you got sperms by Microtesa? I have never considered FSH as a value. A lot of people consider this as a value, but I've never considered this as a value. But if you ask me this question, I've got sperms in Microtesa in Klinefelter syndrome. I've got them in patients who are survivors of chemotherapy. I've got them in undescended testes, which is the most difficult to get. But the truth is, I've never seen the FSH and I've never calculated the FSH. Any size testes, if the testosterone has been brought to a normal size, you could use it. What is the highest level of FSH? Right. Now, indications for TVL in Azuspermia. What is TVL exactly?
I think that is varicose
Ligation.
ligation.
Okay, you're talking of a varicocele ligation.
Hopefully,
See, it's very interesting. There are a lot of papers which are there for varicocele ligation Azuspermia. And there are a few studies in which they actually, after varicocele ligation, have found sperms in Azuspermia. I personally, if you ask me, there are two issues with it. The first issue is when the patient comes to you, he's azoospermic. And if you do a varicocele ligation for this patient, you have to wait another 6 months before you could say that the varicocele ligation has worked or it has not worked. So in these patients, if the patient is ready to take that risk and the patient is understanding that he may not get sperms or he may get sperms which would be lower in number to give a natural pregnancy, which means he may also need an ICSI even after doing a varicocele, you may go ahead with it first. Second, if you do a varicocele ligation in a patient of non-obstructive azoospermia and he's ready to wait for 6 months, then the chances of your retrieval would be higher as per these studies. So that is the role. Now, which technique of TV ligation you recommend? I only use a microscopic level. Reason, you need to see the spermatic artery and save it. Is there any technique in ICSI where we can use spermatids? It's not a question. It's the same technique of ICSI. You do anything which you get, you can put it in. And in fact, round cells or spermatids could be used in case you have not found other sperms. But then the chances of your actually getting good embryos or getting good cleavages is low. I think I have answered all the questions.
Sati madam and Kavita madam.
Hello.
Sati madam, please.
I have a question. The longer the interval after vasectomy and the time of ICSI, the chance of getting good sperms is low, isn't it?
Yes, it is.
How long is the cutoff?
See, what happens with now you've asked a beautiful question. You've asked a beautiful question because it has, I mean, I can speak a day on it, but still I'll summarize it in 4 sentences. The first thing is, whenever a person has a vasectomy, the chances of that person developing anti-sperm antibodies is very high. First. Second, in these people, whenever you do a surgery as a VVA, vasovagal anastomosis, or a recanalization, the chances of success, the more the time has taken place, the more it is less. Number 3, in these men, even if you do a recanalization, they normally do not get pregnant because of anti-sperm antibodies. And in a lot of these patients, ICSI may be needed. So a lot of people are shifting away from recanalization onto ICSI. And as far as ICSI is concerned, you would give an epididymal sperm or a testicular sperm in these men, just as you would get anywhere else. The chances of retrieval or the chances of natural pregnancy, along with, I would say, post-recanalization, would be difficult.
I have one more question. When you are doing ICSI with an epididymal sperm, the motility, the sperm will not be motile. So do you add something to make it move like pentoxiflin?
No, I'll just, you can find in the epididymis motile sperms. First thing. In a testes, you're finding motile sperms is a bit difficult. You would judge now, in case you are taking an epididymal sperm in obstructive Azoospermia, you would, and you find a lot of sperms, you will definitely find a few motile sperms in them. But if you don't find a motile sperm in an epididymal or in a testicular tissue, you need to see a normal sperm. And what we don't add pentoxifylline. What we do is we see a sperm flexibility test. So when you put in the sperm into the ICSI needle, take it out, into the ICSI needle, take it out, there's a flexibility in the membrane of the sperm tail.